name is Nikki. I'm with Classic Air Medical. So thank you for hosting us. We appreciate it. We're going to be talking about airway stuff. The name of my lecture is Airway Management, some pearls of wisdom, and some other stuff too. If you have a question, stop me when you have a question and I'll answer it, or else I'll probably forget it, okay? This is one of my favorite sayings. A difficult airway is something you anticipate, not something that you experience. If you don't anticipate a difficult airway, you're simply not prepared for it. So let me ask you guys this. When you get toned out, what kind of things do you think of in terms of airway management? Let's say you get called to a heart attack, patient unconscious, unresponsive. What kind of things do you think of?
What types of airway devices you can use?
Good. Airway adjuncts?
Yeah.
What else?
Oxygen.
Oxygen? What else?
What is my role?
Oh, very good. Where am I going to be, right? Great. So when we get those calls, we're all sort of formulating plans in our minds, right? So we are anticipating the worst of the worst. Worst kind of call is responding to a single wide mobile home in a bathroom with a 300-pound, 5-foot patient shoved between or wedged between the toilet and the bathtub. That's going to be an airway complication, right? An airway compromise. So we think of what kind of equipment do we need to get in and get out, and how do we manage in between that. So preparation. So we know that the devil is in the details, and the details lie primarily within ourselves. When you guys do your training and you're practicing for your airway, do you mentally practice, oh, I know where this is in my bag, this step comes first, this step comes second? Do you guys use checklists at all?
More of like a.
Pardon?
More of like kind of a process.
Right.
Not really
Okay.
a checklist, but like
Fair
a
enough.
process of elimination.
Copy. So we prepare for the situation, the patient, but mostly ourselves. The standard airway management begins with the assessment. So is this a difficult airway? Is this a respiratory arrest? Is this a respiratory distress? The important thing to know is what algorithm to get into. So if you don't know the difference between an emergency or crash airway and just a respiratory distress, probably like rethink your life. Maybe a rattlesnake roundup, where the only algorithm is don't get bit. When you deal with complicated medical patients, you have an array of things to worry about. Their medications, their side effects, their current situation, the environment, the family, all kinds of things. So the algorithm is really important. The preparation, we talked a little bit about that. We fail specifically in two areas of airway management, preparation and pre-oxygenation. We'll talk a little bit more about that. Our interventions and our reassessment, also part of our standard airway management procedure. So, if in the realm of every single call, you don't worry about mechanism of injury, difficulty with variations of anatomy, and the standard equipment that you have, and if it will work on every patient, because do we all carry neonatal equipment? We don't. So how do we overcome and improvise for those patients? I brought my standard checklist, and I'll pass it around. It's kind of crumpled up because I keep it in my pocket, but if you guys want a copy of this, I'd be happy to make a copy and share it. But the standard airway management includes your equipment. And this should be the equipment that you use for every single call. You'll have your oxygen source, suction, your airway adjuncts, backup devices, a BVM, a way to secure your device, your tube holder, a PEEP valve, Crike setup, waveform capnography, and your SpO2. I put SpO2 predominantly at the back. That is so low on my priority list. What has to be in place for your SpO2 to read accurately? Bueller?
Well, proper intubation, or well, we also have the laser cannula in title, so
Right.
it's I think it's fairly accurate.
Right,
But
I love
for most-
N-Title.
but for
N-Title's
the-
my favorite tool. It's kind of been a game
But
changer
that's
for me.
for more indicative of ROSC for us. If we have a patient who's
Right.
down and all of a sudden we get a jump in entitled, then that's what we're looking for.
Right, but for a SAT, if I
Oh.
put a SAT probe on somebody's finger who's just coded, what problem do I have with a SAT? Are they perfusing well?
They're not.
No,
Just
so-
gonna get more blood.
Right, so you're getting stagnation, right? And you're not getting good, you're not gonna get a good signal. If they've bled out, am I gonna get an accurate reading? No. So there's a few things, if they're super cold, I'm not gonna get an accurate reading. If they're, if they're wearing Lincoln Park After Dark fingernail polish, I'm not gonna get a good reading. So there's a lot of variables with SpO2, whereas N-Title, we get a good waveform, we get that nice square waveform if they're taking nice even breaths. So it's just a better tool. So this is what we should have on every call, okay? And you guys have a lot of medics, so you should know where your credit kit is. So the perfect pearl, I think, and one of my mentors kind of gave me this, the idea of this, is that we don't rise to the level of our expectations. You know how you think, I'm just gonna be so good? We fall to the level of our training, and it's our most basic training. How often do you guys train on Airway specifically?
Yeah, not enough, but like quarterly.
Right. So Keith was just talking about how the AHA just released their new updates, and the emphasis was, hey, stop trying to tube, you're kind of bad at it, and just bag. Be really, really good at bagging. And how long do you say you spend when you're bagging your patients that require a BVM? Anybody time it? Do you guys time your stuff? No? It's okay.
You mean like between rescue breaths or?
No, just time the duration that you're bagging, yeah,
Until
From
they
start-
get to the facility.
right. But you guys have a lot of paramedics, so you should
Yeah.
have like a fair amount of, and even if you're using like a backup device or
I would
Let's
say
move on.
that we probably don't do it nearly long enough because we have so many. Like we'll start bagging them and we'll have 3 paramedics. They're on scene, one's doing airway, so
Yeah, if it's a code, you're gonna probably get 3 paramedics.
Yeah.
So,
fighting over the airway.
yeah, we'll be doing IV, airway, and
Sure.
drugs all
And
within the first
totally-
3 to 4 minutes. So
I'm
it's-
cool with that. I understand that, but probably we should be bagging and doing very effective,
Yeah.
just straight manual bagging, straight up. And the studies show we're really bad at it. So practice. Communication, it's a thing. How often do you guys communicate when you are practicing and then when you're in the field?
we do, my crew and I, we do communication drills where
Love it.
tangle up our SCBA completely, FUBAR, and then blindfolded with gloves on, talk our way through undoing it. So it doesn't necessarily have to be EMS communication, just communication in general really helps overall, in my opinion.
I love what you're practicing is closed loop communication, which is a cornerstone of the AHA's implementation of, hey, how do we do things better? And closed loop communication is super important, like what we were just talking about, how I responded to a interfacility transport on a respiratory patient, and I said, they were like, yeah, we threw the kitchen sink. I was like, you guys gave epi? 0.3, and they're like, yeah. I'm like, I am? They're like, we wish. So they gave 0.3, 1 to 1,000 IV. Probably could have been prevented had they done, hey, let's double check our med and let's implement closed loop communication before we give our med.
Part of the reason why we implemented checklists too,
Right.
and we got it being on the aviation side from aviators, because they show through multiple crashes, they implemented crew resource management, and now we implement it from the ground level too, showing it works. Closed loop communication, double verification, checklists, etc.
So aviation has proved they have changed the way they fly. They've also changed fantastically their safety numbers, their incident numbers. So there's really no reason, it's not enough just to have a checklist. You have to use it and you have to practice using it. So the cognitive offloading is a really big part of it, but it's also, I'm saying this and you're understanding I'm saying this, you're saying that and I understand you're saying that, so that we're all on the same page. One of the things we practiced, before I go on to my next slide, this was an airway class that Kevin and I did at Lifeguard years and years ago. Like you guys, we implemented a video laryngoscopy act, like a practice, and we put blinders on one guy who was tubing, and the guy that held the camera had to talk the guy that had all the equipment in his hands. What that did was it helped with their closed loop communication. It also helped the person who's giving the orders not to give orders, to say, hey, how about we do, you have to watch your words, because sometimes we don't realize when we're like in a code situation, we sound sharp. And maybe when I sound sharp, you're not gonna receive what I say very well. So it's not what I say, but how I say it, but also in the order that I say it, because we don't always, we think when we're talking, if I can just do this for you, there, I've taught you how to do it. But all I did was do it for you instead of talking you through it. And now you're not really helping me and I'm not really helping you. Does that make sense? Mm-hmm. So communication, it's a really big part of standard airway management. So I'm going to tell you one of the other things that we have done in our airway practicing is that we introduce stress inoculation. So when we first start, our medical director makes us do exercises, run stairs, run jumping jacks, do this, do that. And part of our physical, our annual physical assessment is we have to, how many is it, 3 miles? 3 miles and 15?
2 miles.
2 miles and 15 minutes, something like that. So as we're going around, we have to do math problems. And they're like, hey, what's the epi drip dose for a pediatric patient that weighs 3 kilograms? Got nothing but me, and I'm exercising. Hey, what's the tube size for this patient? So the reason we do this, the reason we practice this is because studies have shown when your heart rate gets to a certain place, you're no longer cognitively functioning. It's not that we want you to always perform at that level. We want you to realize when you've hit that level, take a step back, and part of your checklist should be checking yourself. Taking a big deep breath, checking yourself, checking your partner. I'm okay, you're okay, right? So one of the things that is very, very valuable that we don't do quite enough of in EMS is keeping each other in check. And, you know, Keith is really good with me. He'll say, you know, you're tired and you sound stupid right now. So your math is horrible. So how about we take a minute, you time out and you take a nap. And that's good. It's a safety mechanism, not just for he and I, also for our pilot who we fly with, but primarily for the patients that we take care of. So, if the only failed airway is the airway that we can't manage with the BVM, how do we prepare for this? We should be training on a pretty regular basis. One of the things that my old partner Louie and I used to do is we'd be on hitch together for 3 days in a row. And we'd say, okay, Saturday morning, if we don't get a flight, we're gonna do an airway lab. So he would come in and he would shenanigate me. He'd like put KY all over the masks. Or he'd stick stuff down in the airway and we would time each other. So we would kind of set each other up for failure, but make it a game so that we had timed processes in place where we had to complete these tasks. It was fun. It was annoying sometimes because you got to clean it up, but good times. One of the ways we improve our bagging is watching what we do. 2 rescuers, 2 hands, 2 airways, always optimal. And if we can increase that by adding at least 2 inches of elevation underneath the head so that the sternum is level with the earlobe, assuming that the earlobes are not stretched out really big, you know, those big gauges. So you want your earlobes in line with your sternum, that opens up the airway. If you can think of the airway like a straw, and you don't want that straw to bend too far one way or the other, it crimps off.
For everybody? Or all ages?
All ages. And especially for kids, they'll, like, you know, you'll have to put, like for fat babies, you might have to put them, the padding underneath the shoulders, or the toddlers who have the big melons, same thing. But then for, let's see, whoops, I have another one. Your obese patients, you'll have to elevate their head and underneath their shoulders. You guys use PEEP valves?
And then, but we're not really trained on them too
Oh,
much, so.
that's okay. We can make you, it's super easy. I love PEEP. It's the best thing ever. So, do we have a PEEP valve in here? I'll just talk you through it. So, this little red cap screws up and down.
I can
The
get you
farther
one.
down you crank it, the more PEEP you get. What is PEEP? Anybody? Do you know what PEEP is? Positive and expiratory pressure. So it's the it's the stuff that keeps our airways open at the end of expiration. So if you consider your alveoli like balloons, right? You want to keep those balloons inflated just a little bit. Your PEEP is intrinsically at 5, okay? So when you increase that, that just means you're adding the pressure to that end of that breath to keep the airways open. We use that for splinting airways open. It's super helpful with asthma and COPD, even in our respiratory patients that have some type of liquid, pneumonia, those kind of things.
So ARDS patients, it's not uncommon to use 20 centimeters of PEEP.
And you just have to get uncomfortable with that pressure. You just be like, you get comfortable with being uncomfortable. Like, wow, those alarms are going off.
One thing to mention about PEEP too, and I'm sorry if I'm stepping on
please
you
do.
if it goes on. Do you talk about a decreased venous return?
I did not, but let's talk
So
about
one
it.
thing that happens when you're doing, say, you usually see it with 10 centimeters and above. You decrease venous return, increase intrathoracic pressure, decrease venous return, decrease preload, and then they become hypotensive. So it's easy for us because we're like, okay, or you guys can too, the Maddox Levophed, you can throw them on, also known as norepinephrine. So you can throw them on that because they need oxygenation is the most important thing. But in the short term, just remember, if you have that 20 centimeters of PEEP and they start becoming hypotensive, just turn that PEEP down. If you can't if you're an intermediate and you can't start a vasopressor.
Can you adjust the PEEP on your CPAP machine?
Yes, we can on that, and then you're just going to see those on our ventilation circuits that we have for our ventilators. We have just a valve exactly like that.
Okay.
Yeah. Yeah, so it's good. I mean, we just had one up in Penasco that it was an aspiration, head bleed that aspirated, and they were bagging him. He was in the 80s. They just had the PEEP valve on before we were about to intubate. We turned it up to 10, and we got him in the mid-90s for intubation. So it makes a significant difference.
This should be part of your standard airway equipment, so it should be with you, like in your bag when you have it. And I'll tell you, we actually put it on our BVM so that it's just on every patient.
And you would put it right here usually. That would pop off.
One of the things we've started doing since COVID is we have changed from a standard adult BVM to a pediatric BVM. What we've learned over time is that our tidal volumes that we're giving patients manually with an adult BVM, it's just too much. So we've implemented using pediatric BVMs with the PEEP valve, and we'll let you know how it
Yeah,
goes.
any idea how much volume you're getting in one breath with an adult BVM?
It's like 750 to 1,000.
Yeah, exactly.
That's a lot, and the average is 500.
That's on the high end.
That's on the
Like,
high end, yeah.
For me, it's gonna be like 350 or 320, something like that, based on height, right? Do you guys use your ideal body weight and based on height?
Exactly. Yeah.
Right, okay, very good. So, over time, if you've been in EMS a really long time, you kind of recognize that in the past, some of the things you've done have killed people. Remember, I don't know, I've been in EMS like for a long time. We used to hyperventilate ICP, and that meant like 30 to 40 times we're bagging. So what we know now is not what we do now.
What we learned, yeah.
Right, so our volumes are too high. We just have to overcome and wait for the medical suppliers to catch up with what we need. Don't forget, during COVID, when you're bagging a patient, you can do a couple of things. Keep a filter on your patient, especially your circuited patients, the ones that you're using on CPAP. and the ones that you have intubated. And you can use just a regular plastic sheet to keep them covered, to keep the aerosols from spreading whenever you're bagging your patients. So, position, position, position. Can you see how the airway is opened on this woman? And this is kind of a lot of our patients. This is not uncommon. And the blanket roll is simply what we're assuming that we can fold them all that perfectly, because when you're in an emergency, we're like, oh, get the comforter, get the pillow. So you really want to, let's see if I remember which one is which. Is this, no, whoops, sorry, I don't know. So what you want is this line right here for the sternum, okay? Questions?
Hopefully we can find that many blankets.
Right. So what do they say? Necessity is the mother of invention.
Mm-hmm.
You guys have the air pillows on your trunk, right, to stabilize a vehicle? On a big
Oh,
patient,
yeah.
you could totally use that, right?
Yeah.
We use them in the hospitals. They have those pillows that you guys use to stabilize. UNM has them. We stick them under obese patients and pump them up and level them out. Yeah.
We're lucky with the gurney because it just pops up. So
Yeah. Okay.
sticking them on.
Heaven is the criteria that we use to assess and identify difficult airways. Remember, it used to be MOANS. Was it MOANS?
And then lemon.
Lemon.
when we-
MOANS, the acronym. Now there's a new acronym. And the acronym is based on hypoxemia, extremes of size, anatomic challenges, vomit, fluid, and blood, anemia, or exsanguination, and neck mobility issues. It's kind of the same thing, just in a different order. But it identifies the high-risk intubations, the patients that are going to cause you difficult airways. Anything to add on that? Except for that's the Led Zeppelin airway. Stairway to Heaven. All right, let's see. Okay, something that you might not have known. I didn't know this. I learned this last year at the San Juan Trauma Conference. One thing that we don't do, that we need to be doing often, is doing an oral, visual inspection. On kids, it's super common when they have sore throats and difficulty swallowing for them to have these paratonsillar abscesses. If you do your airway assessment and you see that uvula is hanging closer one side to the other, take a quick look with your flashlight and identify a puffy spot, and sometimes there's little holes. So, big source of infection. It could be another criteria for you guys to be like, hey, not just, you know what's going on, not just baby has a sore throat and blah, blah, blah. Questions? A couple of things that go along with this is these patients will probably be very febrile, tachycardic, and tachypnic. So these don't look fun, right? Right. So we have a couple of situations for, well, they're all edematous, but probably anaphylaxis or an allergic reaction, and the one big jaw on the side is either mumps or angioedema. Keep in mind that as your patients present differently, your treatments are going to have to pivot. Now that we're coming up on respiratory season for kiddos, really, really common, a super easy thing to do that is a very comfortable thing, but is also quite therapeutic, is running a saline neb. That cool saline neb, even if it's blow by, feels better to them. Because remember, when they get to a place where they can't breathe and their noses are super congested with RSV or bronchiolitis, they need some fluids to loosen those up. Also, they become mouth breathers. They get real dry. There's a lot of insensible heat and fluid loss when you're breathing fast, especially when it's cold. The role of supply and demand. Patients don't die from not being intubated. They die from lack of oxygenation. That's what our job is. So at the very basic level, we got to put our egos aside and do the basics. And if we're good at the basics, then we can progress. But even at the bedside, sometimes we're like, hey, how about a timeout? Let's just stop and bag for a minute. Let's see where we're at. Let's just do what we know how to do really well and take a minute. If we can oxygenate our patient, we're buying us all a little bit of time. That's a really good book. Okay, the evil triplets. Hypotension, hypercapnia, and hypoxemia. We should be anticipating these patients on every single respiratory call, all right? Now, our anticipation of these also should include our plan to prevent a worsening of these symptoms. What is hypotension?
So low blood pressure,
Okay, so what are some causes of low blood pressure?
low cardiac output.
Low cardiac output? Good.
Let's see, they could be bleeding out,
Okay, hypovolemia?
yeah, hypovolemia.
Good.
Um,
Tension.
Have you heard the pumps pipe fluid kind of way to think about that? So pump is the heart pumping adequately, or, you know, is there fluid around the heart that they have a tamponade? Pipes, you know, sepsis, are the pipes dilated, or the pipes, you know, something going on like that. Neurogenic shock, you have a spinal cord injury, and below that, all the pipes are super dilated, so your volume went from 6 liters to 12 liters with the same amount of fluid. And then, of course, the fluid, you know, are they dehydrated, are they bleeding out? That's the way I,
think of it.
yeah, it works for me.
Possibly.
Sorry,
Okay.
Nikki.
No, please, thank you very much. So some of the things that we need to think about are the time down, the temperature. We need to keep our patients warm because remember our patients shunt when it gets very, very cold and that decreases their ability to oxygenate. Noise, vibration, and any other stressors of transport. So where do your adrenal glands lie? Where are they? Correct. Right? Top of the kidneys. When you artificially stimulate them with lots of noise and lots of vibration, you get this byproduct of this epidump and norepidump, right? So you're artificially creating a stressful environment just by means of moving your patient. So keep that in mind. Do you really need to go code 3 down a dirt road? Because you're stressing your patients more. And remember, the more epi and norepi that's dumped in your patient's system, you're increasing oxygen demand. So you're robbing Peter to pay Paul, and there's a cost to all of it. What's hypercapnia?
CO2.
High CO2. Where do we see that in? Besides our dead patients. Our overdose patients, the ones that aren't breathing, yeah. Our obtunded patients, the ones that are holding on to that CO2, are same thing. Hypoxemia. What's hypoxemia? Low 2. All right. So how do we prevent all of those? We open the airway, assure good exhalation, and then support their blood pressure. Some causes of ventilatory and oxygenation failure. These are these are the staples of why we need to know why we're doing what we're doing. So hypoxic hypoxia, double, hypoxia squared, is lack of oxygen, right? Our end organs not getting oxygen. Hypemic hypoxia is what? Does anybody know? Red blood cells, lack of. Histotoxic,
Infection.
yeah, like sepsis, anaphylaxis, the things that cause stagnation or cause decreased circulation or offset of fluid, and then stagnant hypoxia. We see that also
Crush
in,
injuries?
what's that?
Is it like crush injuries?
Crushing, yeah, crush, and then severe sepsis when they get to that point where they're no longer circulating, you just see kind of modeling. Those are 6 occasions. So if we can identify what area our patients are not oxygenating in, we can address it. So if our patients have low volume, we give them volume. If our patients are hypoxic and they're not breathing, we breathe for them. If their airway's closed, we open it. Decisions. We will take an airway only based on these 3 things. Now, the expected outcome is poor. You guys don't do RSI, but you can get ready for it. And we'll talk more about how you guys can assist or kind of prepare for that situation. And we'll set you up really well for in the lab.
Can you read that top line? I can't.
Yeah, if your patient's unable to maintain their own airway, Airway patency, why do we not use a gag reflex as a means of measurement? Gag reflex is only 30% accurate on the whole population. What we use now is their ability to swallow. If you have a patient that has the ability to swallow, that means they're clearing their own secretions and they can manage their airway until they can't swallow anymore. So oxygenation and or ventilatory failure, those are our patients who are crash airways for you guys. To bear trials with a calm mind robs misfortune of its strength and burden. So I don't know if you notice, I like the Stoics, and I find that there's a lot of really good wisdom in just slowing down. And like in triage, remember the start triage, start where you stand? And sometimes you just have to like take a big deep breath and start over. And this is where your checklists are very, very important, and getting your bearing about you. It's an emergency, yes, but it's, what is this? Slow is?
Oh, slow is fast.
Yes.
Fast
Slow,
is-
smooth.
Yes.
Smooth is fast.
Yeah, smooth, yeah. There you
I
go.
love that. Rush and indecision are not your friends. If you don't know why you're doing and what you're doing, if you're just blindly putting oxygen on a patient because they look sick, you don't know why you're doing it. That's not super helpful. This is where your closed loop communication comes in also. Hey, this is what I'm thinking, what do you think? Not, I need you to do this. Okay, an emergency airway. This is specific for your unconscious and unresponsive patients, or your dead or near dead patients, your patients who do not have a gag. It's not dependent on SpO2 readings during the attempt. So you never look at your SpO2 until after you've placed your airway device in, and you can start reading not just your end tidal, but you're sure that, because your end tidal is going to reflect just circulatory status improvement.
Nikki, do you go into RSI at all in talking the difference between you talked about the emergent airway versus non-emergent airway?
Not really.
Just
We
something
can-
I want to mention about
Okay.
she said don't look for hypoxia. Now say if you have a head injury patient who you know we're going to RSI, look at your SpO2. Look at, of course, end tidal too, but the two things like she talked about on that triad effects is you don't want them to become hypoxic or hypotensive. So you really want to be bagging those patients good, get an NPA, OPA, whatever you can do to prep them, because we won't intubate until it had a huge increase in mortality if you intubated a head lead patient who's hypotensive or hypoxic. So just wanted to touch on that.
No, I'm glad you did. And the same thing works for almost any trauma patient. Our mortality rates are increase exponentially when we have extremes in temperature, is predominantly with cold patients. So, I mean, but that's part of your trauma care sort of package, so something you gotta be.